Hello everyone, Dr. Padmanabhan here. Happy visit to all. I'll be with you probably all of you, most of you remember that I did a video on uh, an abdominal organ called pancreas. So this time I'm doing another video on not pancreas, but pancreas finished over there. I have a video on the liver, which is a close by structure in the abdomen. So liver is it's a very large internal organ. Liver is got divisions. It divided into lobes. It has got a capacity to regenerate, unlike other organs in the abdomen. And it is also our factory in the body which metabolizes all our nutrients. And as you can imagine, it can have a lot of diseases also. And like all other organs, this organ is also not spared of old age diseases. But compared to other geriatric changes in other organs, liver keeps its capacity for a long time. Even when you are in your 70s or 80s, still the capacity of the liver to function is more or less preserved. Though the size of the liver reduces 20-30%, and also its function also reduces. The sinusoid, there is something called sinusoids inside the liver, where a lot of blood flow is there, which brings all the nutrients from the intestine, and then it goes into the hepatic liver cells, hepatic cells, liver cells, for the breakdown, or synthesis. So all this function comes down a little bit. And also the metabolism of, for example, some drugs, especially drugs which has what is called first pass metabolism in the liver, they can accumulate little bit in old age. Otherwise, it's old age diseases like similar to young age disease. And so I'm stressing on this, that the liver does not age so much when you become old, because liver transplants can be done in old people also. And if you need a liver transplant, you can do a liver transplant in old people. It depends upon us. If the person is very frail, probably you should think twice about it. Otherwise, you should do liver transplant if the organ is failing very much. So, but the disease of the liver, actually, there are two types of disease. One is called chronic liver diseases. They are the vast majority. Then there's only another thing called acute liver failure. These are the only two diseases. And its sequelae. These are the diseases of the liver. Chronic diseases and acute liver failure. Two diseases. So what are the chronic diseases? Chronic diseases are the viral hepatitis, that virus which will affect the liver. I'm talking about chronic liver diseases. Chronic liver disease caused by chronic viruses, they are mainly two. One is called hepatitis B virus. Another one is hepatitis C virus. There is some this virus, these viri actually produce damage to liver, not as much by its direct action as by our own immune reaction to it. Like this one, our coronavirus and all. Virus sometimes produce more damage to the body by our own reaction to it, by our immunity to it. So like that, the B virus especially, most of the time B virus would have died out, but the liver will go on getting damaged. And the end stage of all damage is called scarring. The scarring in the liver is called cirrhosis. The scarring process in the liver is called sclerosis. The cells will die off. When it dies off, it gets converted into scar tissue. It's called fibrosis. So that is about hepatitis B and C. But if you find that they are present in the liver, you should treat them also with antiviral drugs. For B virus, there is an antigen called surface antigen, HBsAg, which doctors usually test. And if it is positive, you should treat them with antiviral drugs. The main antiviral drugs with which we treat the hepatitis B virus is the antiretroviral drugs. One is called lamivudine. The same thing which we use for HIV also, lamivudine. The other is called tenofovir and lamivudine. These are the two drugs. Of course, we always used to give interferon before, but interferon is more toxic, especially in old people. So it cannot be given for a long time. Why a long time? Hepatitis B virus has to be treated for throughout life to be of use. Then hepatitis C also, if you think that C will produce an antibody. If the C antibody is positive, you should give antiviral drugs. There are effective new antiviral drugs for hepatitis C. That's one bright spot there. One is called sufosbuvir. 2-3 names are there. Need not remember it. I just saw it in the net. That's why I'm telling you. So, but it's supposed to be very effective, and daily treatment for 6 weeks is enough. Not much drawback. Not like interferon. Before it was all pegylated interferon and this one, I think ribavirin or something like that. For hepatitis C. But nowadays the new direct antiviral drug, it's called direct acting antiviral drugs for hepatitis C. It has revolutionized treatment for hepatitis C. So, but diagnosis again, one has to be very careful in, people are, because most of the time the hepatitis C diagnosis is missed because it doesn't manifest so much with symptoms. So you have to test it serologically. So that's why in disease of the liver, sometimes it may be asymptomatic. Most of the time, liver you have to screen for liver disease. The screening for liver disease is done by testing what's called enzymes produced in the liver, which will leak into the blood when the liver is damaged. Just like other areas like heart also, when the heart is damaged, it will produce certain enzymes which will leak into blood, which you can measure, like troponins, troponin and all those things. Like that in liver, they are called transaminases. There are two types. One is called AST, and one is ALT. ALT is AST aspartic transaminase. Then ALT is alanine, I think. Alanine. Anyway, the function of the enzymes is transamination. Transamination aminating the some products of metabolism to convert or reconvert into amino acids. So it is a enzyme which is used in the liver, and when the liver is damaged, this comes out. There is one more thing that's called GGT. That is glutamyl transpeptidase. Gamma glutamyl transpeptidase. It's called GGT. GGT produces liver damage. It is produced when liver is damaged by alcohol, GGT, or when there is an biliary obstruction. For biliary obstruction itself, there is another specific enzyme called as serum alkaline phosphatase, SAP. In fact, it is said that in old people for screening you can use this one ALT, alanine transaminase, and ALT used to be called SGPT before. SGPT and use SGPT and SAP, that is alkaline phosphatase. Alkaline phosphatase and ALP is enough for as a screening for liver damage. Then if you find there is this transaminase increase, it's called transaminitis. Sometimes it's called transaminitis. Person has transaminitis, that means he has some problem is there. So it can be due to liver damage, or it cannot be due to, because these enzymes sometimes produced from outside liver also. Then another thing is, this can be produced in people having obesity. This can be produced in people having diabetes also. So, but the remarkable increase in this enzyme, probably there is some liver damage. So you have to investigate further and find out. So investigation depends upon your knowledge of the liver disease. So I'll be going on again about the chronic liver diseases. Chronic liver diseases, after the viral liver diseases, then there is a group of liver disease called alcohol liver disease. Alcohol liver, as the name suggests, alcohol liver disease caused by consumption of alcohol, excess quantity of alcohol by humans. Humans means both men and women, that's why humans I said. But in our part of the world, females don't consume so much, I think. Anyway, the alcohol can produce 2-3 types of liver disease, the alcohol liver disease. One is the acute alcohol hepatitis. Acute alcohol, it has it can present with raised, the liver produces, again I said, bilirubin. Secretion of liver is called bilirubin, which is required for the metabolism of fat in the intestine. So bilirubin, if it is not flowing well, it can get into the blood, or there is excess production. Mostly when there is obstruction to flow, it can be seen excessively in the blood. That can be there in the urine. It can be seen reflected in your this one, the eyes can become yellowish, sclera, it's called sclera, the whitish part of the eye is called sclera. It can have an yellowish tinge, that's called jaundice. So they can have jaundice, they can have even ascites, acute alcohol. They can go into what's called hepatic encephalopathy. It's a particular kind of neurological syndrome caused by excess ammonia in the blood. Because the ammonia is also metabolized in the liver. Ammonia produced from urea and all those things, there's some metabolites will accumulate in the blood when the liver is not working. So in alcohol hepatitis, acute alcohol hepatitis, you can have all this kind of, it's a kind of minor kind of liver failure. So that is one feature. Then they have another thing called the fat accumulation in the liver, called alcohol fatty liver disease, alcohol-induced fatty liver disease. There is non-alcohol, it's alcohol-induced fatty liver disease. The fatty liver, because the alcohol is dehydrogenated by dehydrogenase, and that dehydrogenase will increase some quantity of what's called NADH. NADH is some kind of dehydrogenase also, and that in turn will increase the steatosis, or the fat content of the liver, and it leads to fatty liver. So alcohol has a specific action on the liver to produce steatosis or fatty liver. So But it is can be reversible if you compel the person to stop, compel the patient stops consuming alcohol. It can be reversed. Then the most feared complication of alcoholic liver disease is what's called, because of the damage of toxicity of the alcohol, they can go into damage produces scarring. I said, always scarring, and it produces cirrhosis. Cirrhosis, it just means that there is a cir actually means a brownish tinge or a yellowish brownish tinge. That is cir. That refers to the color of the, supposed to refer to the color of the liver, macroscopically, as you see it. Microscopically, this one cirrhosis will be lot of fibrous tissue with islands of regenerated liver cells. That's called nodules. So there will be a lot of nodules as well as fibers. That is the microscopic appearance of the cirrhosis. So alcoholic cirrhosis is supposed to be very dangerous. It can lead to all the complications of cirrhosis. People having alcohol cirrhosis have more complications than cirrhosis caused by other diseases of the liver. So, what are the other chronic diseases which produce this thing? There are 2 or 3 more. Like, I said the alcohol liver, fatty liver, that can also produce this thing. Then without having alcohol, also there is a fatty liver that can also produce cirrhosis. That's the non-alcohol NAFLD, non-alcohol fatty liver disease. There is one is called NAFLD, NAFLD, and also NASH also. NASH means non-alcohol steatohepatitis. That's a more, fatty liver, non-alcohol fatty liver, which is inflamed. That's it. Some inflammation also. The hepatitis also. That is steatohepatitis. It's called steatohepatitis. Non-alcohol steatohepatitis. The NASH. NASH. That will also produce about 20-30% of cases will go into all the complications like cirrhosis. And finally, the cirrhosis will lead to hepatocellular carcinoma usually. About a certain percentage will go into hepatocellular carcinoma. So a certain percentage will develop a condition called portal hypertension. The liver gets all the blood supply from the portal system of the vasculature. Portal means it is the intestine blood which goes to the liver. So that system hypertension will be produced because of the scarring of the liver. The blood vessels will get squeezed and it produce hypertension, postal hypertension. Portal hypertension will cause enlargement of the liver and so many other problems. Main problem is this one, they produce what's called varicosities in the stomach and mainly esophagus and stomach. Varicosity. The veins in the since there is high pressure, whenever there is high pressure in a vein, see the legs, what happens there? When there is high pressure, because of some kind of difficulty in flow upwards, it becomes varicose. Varicose means it becomes like a worm, like this. So varicosity is developed inside but varicosity in the leg and it's different. This is the vessel is very thin, so it breaks very easily. So about it's estimated that in about 5 to 10 years, 30% of the people having cirrhosis, especially alcoholic cirrhosis, will have bleeding from because of rupture of the varicosity. And each episode of rupture producing the hematemesis, or that is blood coming out of the stomach, or vomiting of blood or whatever, will have 30% mortality. 30% of people, 1 in 3 person having this thing, varicose bleeding, will die. So varicose bleeding has to be treated. You have to reduce the portal pressure by giving beta blockers. We used to give a beta blocker called propranolol. Nowadays we give carvedilol. That's what. No, I don't treat all these things. Probably some gastroenterologist or medical person treats it. And I always see, but the geriatric textbook says carvedilol is better than carvedilol. It's also a beta blocker, better than propranolol. So carvedilol will reduce to some extent the portal pressure. Then, but acute bleeding means you have to stop the bleeding immediately from where it is bleeding, that particular thing. You can use a stent there, a nitinol stent. It's called a Dani stent, or use a hematinic powder over there, hema powder, so hema something. And we used to give formerly, a balloon, the tamponade, or that it's called Sangstack and tube. When I was studying for MS about 25 years ago, we were using Sangstack tube. That tube will put pressure in it, then pulled out through the mouth, so it keeps pressure at the bleeding point at the esophageal-gastric junction. But it's a drastic thing. But nowadays they got the nitinol stent. It's called Dani stent. And it is self-expanding nitinol stent, which can be kept for some time. Not like the Sangstack and tube, which can't be kept for more than 24 hours. Otherwise, the esophagus will die or necrose. So this can be used to reduce acute bleeding. Then, of course, all the other things like you can give a vasoconstrictor, mesenteric vasoconstrictor. Mesenteric vasoconstrictor. Pitocin analog. That vasopressin analog, terlipressin can be given. Terlipressin can be given, or even vasopressin, or sometimes we used to give octreotide for this thing, bleeding. So octreotide is a life-saving drugs sometimes, but mortality is pretty high, 30%. 1 in 3 will die. Well, we have seen it literally as surgical students and all that. So people die of this thing. Even after that, when I was doing general surgery, some people coming with this one massive hematemesis will not make it. So that's a liver complication. Liver can also have other complications like there are accumulation of fluid in the blood, abdomen. It's called ascites. Ascites means a big bag. So because abdomen will become a big bag full of fluid because the cirrhosis will have portal hypertension produces mesenteric vasodilatation, and mesenteric vasodilatation in turn produces some effect on the kidneys, and they will ask the kidney to conserve, keep the sodium. So the sodium level go up. So to compensate for that, water excretion also goes down. So the main treatment for ascites is a diuretic, mainly diuretic, potassium-sparing diuretic. Spironolactone is given. Spironolactone, nowadays some other analogs of spironolactone can also be given. It can be given in massive doses. Spironolactone, one tablet comes as 50 milligram. You can give it up to 400 milligram. If it doesn't produce, if the person doesn't have kidney disease, because it can also increase the level of potassium in the blood. But a high dose of spironolactone, if spironolactone alone is not functioning, you can add a loop diuretic like furosemide also. See, this is I'm mainly talking to people who are connected to the medical fraternity. But I'm sure people will understand what diuretics are. Diuretic means it will take the fluid out of the body through urine. That's a diuretic. So when you give a good diuretic, the ascites, that's the main treatment for ascites. But if it's a tense ascites, then you have to take out the blood manually, surgically. Aspirate it, maybe 4 or 5 liters sometimes. If you take out such massive amounts of fluid, there can be some vascular result, like vascular hypertension, things like that. So you have to give, when you are taking out so much of fluid, probably give salt. It's called salt poor albumin, IV. Albumin is extra. I don't know how many people give albumin. But that has to be given. Otherwise, sometimes we can have vascular collapse. Then I said there is a mesenteric vasodilatation. The same process can also induce, I said it will induce the kidneys to conserve sodium. The same thing, because of vasodilatation, can produce vasoconstriction in the renal vessels, vasculature, and produce renal failure. That's called hepatorenal syndrome. That's also a complication of this one. There are five complications of this one, cirrhosis, that is the scarring of the liver. Five complications. First one is bleeding. Bleeding, I said, ascites, hepatorenal syndrome. Then the scarring predisposes the liver to go into become malignant. Malignant means the cancer. It's called hepatocellular carcinoma, HCC. So anybody having this kind of problem in this one, we are talking about this one, cirrhosis, fibrosis of the liver, otherwise called cirrhosis. So cirrhosis can become degenerate into hepatocellular carcinoma. So you have to actually those who have, especially those who have cirrhosis because of viral hepatitis, post-viral hepatitis, or alcoholic hepatitis, or because of metal disease of the liver. That's all. There are two chronic diseases because of metal accumulation. Metal means one is because of accumulation of iron in the liver. That's called hemochromatosis. Hemo means blood. Chromatosis. Chromatosis, color of the iron. Hemochromatosis. Another one is called Wilson's disease. That is excess deposition of Wilson's disease of very young people. So that we may not see in old people. But these two can produce chronic liver disease. But the thing is that these diseases are eminently treatable, in the sense that if a person has hemochromatosis, a lot of deposition of iron in the liver, you can actually take out his blood periodically. That's called phlebotomy. So periodic phlebotomy can be given. So that will reduce the iron load in the body. The iron load is measured by a iron substance called ferritin in the blood. Ferritin in the blood. Ferritin, another 2 or 3 things are that transfer in all those things. So so it's treatable and sometimes we give what's called chelating agents like desferrioxamine, like penicillamine and tramtorine and all these things. So chelating agents can also be given. So it's a treatable disease, and if it is treated before the real occurrence of this one cirrhosis, probably they can have a normal lifespan also. So these two are the see, liver is also affected by autoimmune disease. Uh, autoimmune hepatitis is very well known. Autoimmune hepatitis, in the setting of somebody having autoimmune disease, somebody having developed transaminitis or develops liver failure or cirrhosis, then you have to think it is caused by autoimmune disease. So, how did you arrive at all these diagnosis? All these diagnoses, cirrhosis, then autoimmune hepatitis, viral hepatitis, they can also be seen not only by measuring the biochemical values in the blood, but by radiology also. Radiology means ultrasound, CT and MR. It's said that CT is computed tomography with contrast is very good. But nowadays they have got a high impact magnetic resonance imaging, which is equal to one magnetic MR without contrast is equal to CT with contrast. That is the suggestion. So MR maybe it may be more useful in some cases, especially find the diffuse process in the liver. Powerful MR imaging is very good. So that's the way how you diagnose. But diagnosis, the gold standard is always take a biopsy. But nowadays you try to avoid biopsy, liver biopsy as far as possible, because liver biopsy can give rise to bleeding and even certain percentage of mortality can be there. It's an invasive procedure, even if it's done under ultrasound guidance. Sometimes the person has bleeding diathesis, bleeding problem, and people having a liver disease they generally have. So you have to correct that bleeding problem before doing a liver biopsy. But most of the time we can get away without liver biopsy by getting the imaging plus the biochemistry. Plus there are some other tests also, like something called fibro test. Actually, that can calculate the amount of fibrosis in your certain biochemical parameters, 5-6 biochemical parameters. Then there is some fibroscan is also there. Fibroscan, it's called elastography. That is why what you do is you put this thing ultrasound, which can measure the elasticity or the fibrous tissue in the liver. Elastography, that is so combining this one HEPA test, elastography, you can actually arrive at elastography. It is said that that is measured in the result is measured in kilopascals. If even if fibrosis is there, if it is less than 19 kilopascal, the likelihood of the person bleeding from esophageal virus is quite low. So now the non-invasive way also we can diagnose all these things. So time is flying. So I'm just going to. This is a chronic liver process. The end stage of chronic process of the liver, chronic disease of the liver is, of course, I had to leave this one autoimmune hepatitis. I told you already. There is another autoimmune process called primary biliary cirrhosis. Primary biliary, so PBC. PBC is usually diagnostic criterion is antimicrosomal antibody in the blood. Antimicrosomal antibody, AMA, antimicrosomal antibody in the blood. That is high, and plus deranged hepatic biochemical values, and also sometimes goes into cirrhosis, jaundice, all those things, liver failure, then that means it is having autoimmune hepatitis. So, so this will lead to cirrhosis, malignancy. Then these are the chronic disease of the liver. I go to into acute liver disease, acute hepatic failure. Acute hepatic failure is usually due to a few things. One is the viral virus. A virus, B virus, E virus. A, B, E. E is rather interesting in the sense that apart from the liver failure, they can also have some neurological symptoms, like Guillain-Barré, some the sensory symptoms, and also there can be there. So virus, then alcohol, it produces acute liver failure, alcohol, and then drugs also. Drugs like anti-tuberculous drugs, even antibiotics, any drugs for that matter. If the person can have an idiosyncrasy in going to acute liver failure. Acute liver failure means there are two things. The person will have high hyperbilirubinemia, high bilirubin, sudden deterioration, and they can go into multi-organ failure. And of course, hepatic encephalopathy, all those things. And mortality is very high. In acute liver failure, mortality is very high. And you sometimes treat them with, symptomatically, sometimes in drug poisoning, you like with paracetamol, you give acetylcysteine, this that kind of drugs. And but if all these things fail, you have to consider if the life is very valuable. Every life is valuable, whether it's young, especially young people. Sometimes probably you can give liver transplantation. That's actually a criterion, King's College criterion. If the bilirubin level goes more than 17.5, or the INR becomes more than 2.4 or 3.4, something like that, then you should have considered immediate liver transplantation to save the life of the person in acute liver failure. So these are the things, and as I said initially, liver failure is should not be denied to an old person just because he's old. It depends upon his health. If he's healthy and he's abstinent from alcohol, always consider for liver transplantation. With this small note, I think I will stop my short talk on liver diseases. Liver diseases with a slant on liver disease in old people. Thank you very much.